it will automatically blank out. But those of you who have your own laptops, we have an electronic counter which will be kept here. So you will know how long or how much within time you are. And the moderator would please try and restrict the speaker to about 15 minutes. So we'll start with the first session. The theme for the first three lecture sessions are intrathecal anesthesia, epidural anesthesia, and pharmacology. So each session is going to be moderated by an expert. There will be no question and answer session at the end of each lecture. All of it is going to be done at about 6:40. We are just about 15 minutes behind time. I expect it to be around 6:40 or so. So at the end of the day, we can have a complete heartfelt question and answer and anything that you want to ask. Right? So we start with the first, intrathecal anesthesia. The moderator for this is Dr. TVS Gopal, who is the founding managing director of Axon Associates. And the first speaker is Dr. Kumar. The topic is assessment of spine for neuraxial anesthesia, clinical and radiological.
And in front of all the experts here. Why? Because with experience of 10 years, most of you would have done about 9,000 blocks. And I'm talking about a very basic subject. I think everyone knows the importance of anatomy in regional anesthesia. The only thing here I would like to emphasize is that the interlamina space increases as we come down. So suppose you have a failed block at one level, you can come down, the chances of success is better. Now this is one point which we have to see is the sacralization of the lumbar vertebrae, where the fifth vertebrae becomes sacralized. Here what happens is we have only 4 lumbar vertebrae, and when you count there may be an error of 1 vertebra, which may not be significant in normal patients, but in elderly patients who have compressions, fractures or anything, it may be quite significant. Same thing with lumbarization. And a lot of sacral anomalies can interfere with our caudal blocks because of the sacral hiatus anatomy. Now, all of us know about the 3 ligaments which we go through. There may be textural changes which can alter our tactile feel, which can interfere with our regional anesthesia. And we should be aware where the cord ends and where the durameter ends in the different age groups. Now, the most important in assessment of the spine is the identification of the midline and the identification of the interspace. If we do these 2, I think we'll be successful. What is successful? Ideal placement of a neuraxial block, the first attempt at the first level with no redirections. In this, very difficult, but you can see the gluteal crease and ask the patient to feel the midline of his back. That may give us a clue. Here you may feel the midline because of the rotatory effects. You may not get into the neuraxial axis. Now, quite often we do not identify the interspace properly because of the error in the intercrystal line. So we anesthesiologists could identify only 29% of the time correctly the spaces. Up to 51% we are in an error of 1 space. And in this study it was very well shown that the spinal cord ends below the L1 level, which can still cause problems to our neuraxis. Now, summarizing all the clinical studies which are assessed, how we can identify a difficult spine. The most important is the spinal landmarks. Next comes the spinal deformities, the body habitus, the provider's level of experience and elderly. Needle type approach, whether it is spinal or an epidural, doesn't make a difference. Now in this study they found the interspinous space is very important, and if the interspinous space is less than 6 millimeters, 28.3% required more than 3 redirections, 28.8% required more than 1 attempt, and if it was less than 6, 15.9% required more than 1 level of attempt. So combining all this together, I think it's worthwhile putting into a development of a difficult spinal score, which includes age, BMI, the spinal bony landmarks, deformities. If the score is more than 4, I think it will be taken as a difficult spine, and I think we should make efforts to how to plan our anesthesia. This quite commonly seen in children. A sacral dimple, don't take it lightly because it can be associated with occult spina bifida. We can be in this situation like this great man, and that is so get into basics. Now, what help can we take? Radiological, you can take help of the X-ray, which is an adjunctive but quite an important role. You can have evaluate CT, which gives an excellent view of the vertebral bodies. MRI essentially is useful for the spinal cord and the soft tissues. Newer development is with the data from the CT, you can have 3D reconstructions which will give a very good view of the vertebral bodies, the evaluation of the soft tissues, and also we can rotate the levels in such a way that we can get access into the intervertebral spaces very well. The only drawback of this is they are all in supine position. It does not translate into our clinical situation where we are using a lateral position. Now a simple spinous X-ray of the spine, you can identify the various structures. You can see the interlaminar space very clearly. You can choose which space we want to go. Now this is a case of spine fusion with an autologous graft. Can we go ahead with the regional here? But if you see here, the spinous processes are all intact, the lamina are intact, the interlaminar spaces are good. So I think there's no harm in going in for a thing. But the same thing here, with an implant in situ, there is no spine, there is no lamina. Now we must have very valid reasons to go into regional anesthesia technique in this. Now the 3D advances in spine is very useful to us. It can pick up what is this called as a supraspinous ossification. With the 3D reconstruction, you can see the supraspinous ligament is ossified for about 3 segments. If you come lower down, it's not ossified. So you can plan our anesthetic procedure in the midline. The same thing on a 3D reconstruction, you can see very clearly that this space is clear and we can access this space. Now the same supraspinal ossification can be focal, and here you can see it between L5 and S1. So we can avoid this. That's the usefulness of the investigations. Now we have an entity called interspinous osteoarthritis. These are very common in elderly age group and also in young athletes who have a lot of flexion and extension of the spine. Now how does this present? This is because of crowding of the interspinous spaces. So we cannot access the space in the midline. You can see the same thing in a 3D construction. Or it can present as an interspinous ossification also. So it will hinder our movement. So the plan here would be a paramedian approach instead of a midline approach. Now facet joint pathology is quite commonly seen in a lot of patients. So you can see the osteophytes here, or you can see a cyst here, and you can plan your procedure. Here probably a patient would benefit from a midline approach. Now this is one difficult case where scoliotic spine 3D is very, very useful here because it can give a very useful information about the interspinous and the interlaminar spaces. Anki is a very common thing which we face, and once again 3D reconstructions are very useful. You can see here the L5 and S1 spaces thing. All the other spaces are ossified. So there's no point in trying and thing. Now on the axial axis you can see the midline is free, but in other places there are extensive bony bridges, so I don't think so we should venture into a uniaxial block. MRI is, as I told you, it's very useful for the soft tissue and thing, especially for complications following regional anesthesia. It's very useful. You have a T1 and T2 thing. The fat and the CSF contrast with each other and gives us a very valuable information. This is one of the normal studies. Now, this I think we should see in our CT scan, the MRI scans when we see the patients, that these are all CSF around the cord. Now this CSF volume is very important in the variations which we see between patients, and also it's implicated in some, the CSF volume is very high, it's implicated in failed spinal anesthetic. Now MRI has picked up an epidural cyst. Obviously regional anesthesia is not indicated here, especially because the CSF flow pattern also changes. The same thing you can see in what conditions called as Tarlos cysts. Tarlos cysts are cysts which communicate with the CSF, and it's quite seen in about 25% of the patients, and they are quite asymptomatic. Now this is one thing which we should be aware about spinal stenosis. The AP diameter becomes narrowed, and a lot of patients are asymptomatic. We may not be able to pick up. Now this study, a retrospective study about 937 patients, they found that higher incidence of neurological complications after neuraxial block. Now the blocks are multifactorial, and it's based on the double crush syndrome, where a single thing may not be very obvious, but they join together and cause a complication. Now we should use judicious judgment in such patients whether we should go ahead with the neuraxial block or not. Now this is a great advancement for anesthesiologists because we can use it on the table, and it's very useful to us. How is it useful? We can mark the midline very easily, even in obese patients. You can count the interspaces from L5 onwards. You can identify the best interspace. This is how we have done in one of our patients. And this one of our Anki patients, we had a limited window. We have marked it here. You can see we had put in the spinal needle, and you can see the thing. And this was all done in a single attempt. Now we can accurately measure the epidural depth so that we know we do not damage the opening. And also the needle trajectory can be measured. Now lastly, this was a patient who had a section with us, uneventful spinal, and the anesthesiologist noted in his PSC notes that there is a tenderness in the T7 level. 2 months later, patient came with a paraparesis, and then when you see this, there's a tuberculous pathology here which required decompression. Now if this had happened immediately post-op, anesthesiologists would have been blamed. So how much we investigated, how we go about it, is we have to take it on a case-to-case basis. In summary, landmarks are the single most important in the success of neuraxial anesthesia. I think we should make every effort to do that. We can utilize ultrasound as it facilitates neuraxial anesthesia. Radiological investigation help in identifying the spinal pathology and in planning of the needle approach.